First, we'll decode patient safety. Then, look at consent and IV protocols. Break down the famous surgical safety checklist. Step right inside the operating theater. And finally, we'll track blood loss.
Section 1. Decoding patient safety. Let's head into the ward where everything starts.
Before a doctor even thinks about doing a procedure, we really need to get a handle on how hospitals legally and medically define safety incidents. They break these down into three main categories. First up is an adverse event. This is when unwanted harm actually happens. Think of a patient getting a test dose of a strong antibiotic like clindamycin without their chart being checked properly, right? And boom, they go into severe anaphylaxis and cardiac arrest. Next is a near miss. This is exactly what it sounds like. An event that could have caused harm, but someone caught it just in the nick of time. Imagine a nurse about to accidentally inject a highly cardiotoxic or heart-damaging painkiller into an IV line, but they realize the mistake seconds before pushing the plunger. And finally, we have a no-harm event. This reaches the patient, but doesn't actually injure them, like, say, giving a simple enema to the patient in bed 13 instead of bed 12. Now, here's the really interesting part. Hospitals actually consider tracking those near misses as the absolute most vital method for checking how robust their safety systems really are. Section 2. Consent and IV protocols. So, our patient is settled in, and it's time for the very first physical interventions on the ward. That means getting legally binding written consent and hooking up an IV line. Now, getting consent is absolutely not just about scribbling a quick signature on a dotted line. A proper consent form has to spell out the procedure in totally simple terms. It also has to outline risks that are specific to that patient. Like if the patient is diabetic, the form needs to note their higher risk for wound complications. And get this, the surgeon is legally required to list any surgical complication that has more than a 1% incidence rate. That 1% is a crucial threshold. Plus, they must explicitly list alternative procedures. So even if a patient insists on a full mastectomy, breast conservation surgery still has to be written down as a discussed alternative on the form. Once that consent is locked in, the patient needs an IV. Medical teams use color-coded cannulas, and they memorize a really counterintuitive rule. The lower the gauge number, the wider the actual tube, which means a vastly faster fluid flow rate. The orange 14-gauge cannula is massive. It can pump an astonishing 270 milliliters of fluid every single minute. Meanwhile, the narrowest one, the violet 26-gauge, has the absolute slowest flow. And this color coding directly dictates life-saving protocols. Picture a trauma or burn patient rushing in. They're hypotensive, their blood pressure is crashing, and they are severely dehydrated. They need fluids, and they need them literally right now. The medical team is instantly going to grab those widest bore lines, the gray or orange ones. But there's a trade-off. These thick IVs carry a high risk of something called superficial thrombophlebitis. That's a super common complication where the vein gets inflamed, and it basically feels like a hard red cord right under the skin. It's painful, and it can take months to resolve. Section 3. The surgical safety checklist. Our patient is prepped and rolling out of the ward toward the operating theater. Now, anyone would be terrified right now, right? We've all heard the absolute horror stories, a surgeon replacing the left knee instead of the right knee. But check out this statistic. Since corporate hospitals started widely using surgical safety checklists, mortality rates for hospitalized surgical patients have absolutely plummeted. We're talking a drop from 1.9% all the way down to just 0.2%. It's a stunning victory for simple organization. And the checklist responsible for saving all those lives? It's split chronologically into three crucial, non-negotiable phases: the sign-in, the timeout, and the sign-out. Let's walk through exactly what happens at each step. This sign-in phase kicks off right when the patient gets transferred from the ward to the OT complex. The team confirms the patient's identity, checks allergies, and then, this is absolutely critical, a team member physically marks the surgical site on the patient's body using a non-erasable marker. They actively ask the patient, hey, is this the correct side? They cross-reference the chart, and honestly, until that permanent ink is physically on the skin, the surgical nurse will flat out refuse to let that patient enter the theater. Next up is the time out. The patient is on the operating table, but before the scalpel even comes close to the skin, the circulating nurse calls a time out, and everyone in the room just freezes. In massive hospitals, staff might not even know each other, so everyone goes around the room introducing themselves by name and role. The surgeon states the procedure and how long it should take. Then the anesthetist verbally confirms that the prophylactic or preventative antibiotics were already given perfectly on schedule, usually 30 to 60 minutes before this exact moment. Section 4. inside the operating theater. The timeout is complete, and we're officially crossing the threshold into the highly controlled, sterile environment itself. The operating complex is basically a fortress, divided into really strict geographical zones. First, you enter the protective zone to change into scrubs and pass through pre-op. Then you move into the clean zone. This includes the connecting corridors and, crucially, the equipment storage rooms. From there, you finally cross into the aseptic zone, which is the actual sterile operating theater. And any waste generated, that goes straight out through a totally separate disposal zone to avoid any cross-contamination. Once inside that sterile aseptic zone, how you position the patient on the table is everything. Gravity literally becomes the surgeon's best friend. Take the Trendelenburg position. The patient's head is tilted down and their feet are up. Why? Because gravity pulls the bowels away toward the head, giving the surgeon perfectly clear access for pelvic surgeries. The reverse Trendelenburg is the exact opposite. Head up, feet down. The bowels drop down into the pelvis, which opens up perfect access for upper abdominal stuff, like laparoscopic gallbladder removals. But these life-saving positions come with some serious risks if the team doesn't execute them flawlessly. In the lithotomy position, where the patient's legs are up in stirrups, if the supports aren't perfectly padded, they can actually crush the common peroneal nerve in the leg. Or take the lateral or sideline kidney position. If the arm isn't placed right, it can dangerously stretch and injure the brachial plexus nerves. Oh, and here's a wild one. After a reversed Trendelenburg laparoscopic surgery, patients often wake up with referred pain in their right shoulder tip. This happens because the carbon dioxide gas used to inflate the abdomen gets trapped right under the right side of the diaphragm.
One of the most fascinating setups is Fowler's position. The patient is literally sitting up, which is often used for neurological or breast reconstruction surgeries because gravity pulls the blood down, giving the surgeon a totally bloodless field to work in. But it comes with a truly terrifying risk. Because gravity empties the veins in the upper body, those veins actually develop negative pressure. If a surgeon cuts one without realizing it, it acts like a vacuum, sucking air straight into the heart and causing a fatal air embolism. To stop this, surgeons have to meticulously tie off or ligate every single vein before making a cut. If an embolism does happen, it's total panic mode. They instantly throw the patient into Duran's recovery position, rolling them onto their left side with their feet up. This traps the air bubble on the right side of the heart so they can desperately try to suck it out with a needle.
Section 5, Tracking Blood Loss. We're at the final stage of our journey. The surgery was a success, the skin is being closed, and that critical third phase of the checklist begins. During the sign-out, the nurse starts an intense, loud counting protocol. They have to verify that every single piece of gauze, every mop, and every needle opened before the surgery is physically accounted for. Any tissue they removed gets properly verified and labeled. And then there's usually a bit of a debate about blood loss. You see, surgeons are kind of notorious for underestimating how much blood the patient just lost. Because of that, the protocol is incredibly clear. The anesthetist, not the surgeon, gets the final, objective say on the total blood loss.
And the way they calculate that is with some seriously precise math. The medical staff knows for a fact that one fully soaked surgical mop holds exactly 100 cc's of blood. A fistful of blood clots, that equals about 500 cc's. So they do this brilliant little equation. They take the total volume of fluid inside the suction machine, they subtract the clear irrigation fluid they use to wash out the surgical cavity, and then they add in the totals from the soaked mops and the clots. It is literally life-saving arithmetic.
But what if human error strikes? What if the counting fails during the sign-out? Well, there's an ultimate fail-safe. If you look closely at surgical mops, they actually have a thick blue radio-opaque line woven right into the fabric. This clever addition means that if a mop is ever accidentally left inside a patient's abdomen, a simple, quick X-ray right there in the room will make that blue line instantly light up on the screen. The surgeon can retrieve it before the patient ever leaves the operating table.
Which brings us to the end of our journey today.